All right, it's that time. We're going to go over the retrograde IV. This particular post has gotten so many views, so many likes, so many shares, and so many comments. So let's discuss the retrograde IV. All right, so as you can see here, the picture on the left is an IV that's placed normally. The IV cannula is facing up the arm towards the heart, right? So the IV is facing towards the heart. Whereas in this picture on the right, the IV is facing away from the heart and towards the hand. So this is what we would call a retrograde IV, just in case you're new here. Let's just go over some basics of vein physiology. So we know that veins return deoxygenated blood to the heart, and they carry that blood under lower pressure compared to arteries. And we also know that veins contain valves that prevent the backflow of blood. So like we discussed, the norm is to place the IV cannula facing towards the heart so that our fluids, our blood products, our medications will go towards the heart and then distributed to the rest of the body. Now, I know a lot of you had said that there had been times where you accidentally placed them backwards, and we're only human, we make mistakes. This is not to shame anyone because we have seen it in practice. Many people have done it. If you have done it, you are one of the many. So that is okay. If you find that you've done this, you've placed it backwards, just remove the cannula and recite it. So we're going to go over a few studies, some that you guys talked about in the comment section, and just a few other case scenarios where the retrograde IV would be applicable or was applicable. The first one is this comparison between the retrograde and antegrade peripheral venous cannulation. This is the ICU case study or observational study that assessed the formation of thrombus. So just so you guys know, this was a monocentric, non-blinded, prospective observational cohort. So it happened in one place. It was non-blinded, meaning both the researchers and the participants knew what was going on, what was being given in terms of treatments and intervention. It was prospective, so the study followed the participants over time, and it was an observational cohort, so the researchers didn't intervene or manipulate the study subjects in any way. They simply observed and recorded information. So there are pros and cons to a study like this. The pro is that there was a clear timeline, and which is a good thing, so you can kind of see how things unfold. You can get multiple different outcomes out of something like this. So that can be a pro too. It's useful for studying like things that are not common. So the retrograde IV, which is a not so common practice, it gives us exposure to something that's pretty rare. But there are some downsides to this case study, which I wanted to really touch upon. Number one, this was a 40 patient cohort. So when we're talking about things that change practice, 40 patients doesn't really make a dent in the matter. We need way more study, way more participants, or way more people to prove that something is evidence-based and that it can actually change practice. So I wouldn't use this particular study to say this is normal, this is okay to do. Now, what I will say also in this particular study was that 100% of the patients had thrombus formation. So you guys hear that? 100% of the patients ended up getting some type of thrombus formation in their IV. The difference was that the one with the retrograde, the backwards IV, took a little longer. So I think it took about 6 days, whereas the regularly placed IVs took about 3 days. So that does tell us something, but the problem also is that in some of these types of studies, especially in observational studies, we can't prove that one thing causes another because everything is very much in a controlled setting. So that was one of the studies that you guys discussed. The next one is a really good one. This one was written by Lynn Hathaway. This is about giving medication by retrograde infusion. The actual study or the review talked about doing this for neonates, so not in adults. This is a practice that can be used in a very special situation for neonates when you have to give them a volume dose of about 1 ml or less. This can be an alternative way to infuse that type of medication in the neonate population. But again, not for adults, so not something that we can just take and use for regular practice. Now, this last clinical trial or last study was a study to determine if drawing blood from the hand with a retrograde IV improves the consistency of the intravenous glucose tolerance test compared to drawing blood from an arm vein with a regularly placed antegrade catheter. Again, this was a very specific study, and they just compared the insulin response levels between the hand site and the arm site. And pretty much the conclusion that they had was there was no result. There was no difference in the consistency of the IVG-TT results. They also realized that the hand veins with the retrograde IVs failed at higher rates than the antegrade IVs. And the failure rates, which is just a little fun fact, were particularly higher in female subjects than male subjects. So again, not something that we would use to change practice. So pretty much in conclusion, would we actually use this in regular practice? No. When it comes to retrograde IVs, there's going to be an increase in catheter-induced phlebitis because it's going against the flow. We already know that some studies show that there are higher failure rates when placing an antegrade IV. So for those of you who are saying, well, if it's in, you're going to probably have a higher failure rate or a quicker failure rate than one that's placed normally facing towards the heart. And then think about the patient's discomfort or comfort level. They will probably be more uncomfortable because it's going against the natural flow of blood, and it will cause more irritation. When we talk about retrograde IVs in practice, these are very controlled settings where these people are being monitored. In the first study, they were doing daily ultrasound assessments of each patient. Can you imagine doing a daily ultrasound assessment of your IV just to place it backwards? It just doesn't make sense. So in conclusion, I truly believe that a retrograde IV should not be used in clinical practice. If it's in backwards, it should be resighted and placed forward, placed the right, correct way. You don't just place things backwards and say, oh, well, it's in, we're just going to use it. That's just not good practice. We don't have enough to say that this is okay. We have more evidence that goes against it. So that's my take on retrograde IVs. If you guys have any other questions, concerns, if you don't agree with anything I said, please let me know and we'll discuss it.